All right, guys, let's get busy talking about bipolar disorder. Now that we have a pretty good firm grip on what is mania versus hypomania, differentiating bipolar disorder from bipolar 2 disorder becomes really easy. So let's go ahead and talk about it. When we talk about bipolar 1, all we really need is greater than or equal to 1 manic episodes. Now, our patients can also have depressive symptoms, but this is not a requirement for the diagnosis. All we need is a diagnosis of true mania, and that qualifies you as having bipolar 1. Now, when it comes to bipolar 2, we're going to have greater than or equal to 1 hypomanic episode plus a depressive episode. This is the diagnostic criteria for diagnosing bipolar 2. And we already talked about the difference between overt true mania and then hypomania, which is like the diet version of mania. So in bipolar 2, we're going to have no evidence of overt mania, and we're going to have increased functionality compared to bipolar 1 patients. And we talked about that before, how with bipolar 1, with true mania, these patients are going to have really tense like social and professional interactions because they are just totally wigged out. Whereas people with bipolar 2 are able to go through life a little bit easier because they are not at such a high energy level. So if we go back to our graph, remember our axis here when we're talking about bipolar is going to be in order of days. We're going to have a level of energy for bipolar 1 that's going to be really, really high. Like we're up here in overt mania for upwards of 7, 8 days, and then we might come back down. Now, in terms of bipolar 2, we're going to be in hypomania. So we're going to be at maybe like an energy level here, not for quite as long. And then we're going to come back down, and we need to have evidence of a depressive episode as well. So I'm going to show that by our mood dipping down low at some point in our graph. And this is showing you that the diagnosis of bipolar 2 requires that depressive episode, which we highlighted earlier. So I'm going to re-highlight that in yellow. That is not required for bipolar 1. So that's another way to differentiate. Also, patients with bipolar 2 are rarely going to be hospitalized. So it's another easy way to differentiate these two disease processes. Now, it's really pretty easy to recognize hypomania or mania on exam because they really hit you with a lot of high energy symptoms that are easy to recognize. However, test takers like to really trick you up when talking about management and the side effects associated with it. So we already talked about the fact that SSRIs can cause mania or worsen mania. And so we always want to screen our patients for a history of manic episodes. And if they have them, we want to avoid SSRIs in that population. So I would say that's like the first thing that you want to be on the lookout for. Now, when we actually get to therapy, I would say the number one therapy that's going to come up is lithium. So it's important to talk about some of the side effects of lithium. So we're going to have tremor, nephrogenic diabetes insipidus, renal failure, hypothyroidism. These are all classic things they may describe in a vignette of a patient who had bipolar or bipolar 2 and is being treated with lithium. Now, this is not an exhaustive list of symptoms. These are just the higher yield ones that I think come up most often. We also can use valproic acid, so be on the lookout for pancreatitis and LFT elevations with that. Also, we're going to be on the lookout for SIADH, osteoporosis, agranulocytosis, and aplastic anemia. That is associated with carbamazepine. This is a really nasty drug that has a lot of side effects, but sometimes it's used for treatment of bipolar. Next on the list is going to be lamotrigine, which causes Stevens-Johnson syndrome. So that's something to be on the lookout for this. Some other adjuncts that we can add on are going to be the atypical antipsychotics. For some patients with mania, they also present with psychotic symptoms. So we can add on an antipsychotic for patients that are experiencing these symptoms of psychosis. We usually use the atypicals because they have a nicer side effect profile, but usually these might cause galactorrhea or weight gain as primary side effects that are going to be mentioned on exam day. Now, I just want to reiterate one more time the importance of avoiding antidepressants because these worsen mood disturbances, and this can cause suicide risk. So always, always, always screen for mania. And if you have mania, you want to avoid things like SSRIs, and always, always do a suicide risk. And if they are at risk of suicide, this is going to require hospitalization and further monitoring to ensure that our patients stay safe. The other thing that I want to touch on is our three most common drugs for treating bipolar disorder are all teratogenic. So I'm going to make these black bullet points here and kind of put a black bracket around these first three because these are all teratogens. And so if we're mentioning something to do with pregnancy or childbearing age or like the plans of a female patient to have babies, these are three that you absolutely want to avoid in patients with bipolar disorder who have plans or possibility of getting pregnant. A good choice for patients with pregnancy is going to be lamotrigine because this is most well tolerated during pregnancy and it has the least chance of giving teratogenic effects. Lastly, let's talk about cyclothymic disorder, which is going to be a disorder related to both bipolar and depression. And it's basically a milder version of both of these disease processes. So there's no overt depression or mania, and it happens for a long time. So this is on the order of greater than or equal to 2 years, with less than or equal to 2 months of remission. So on our time versus energy graph here, I'm going to change the x-axis here back to months for our sake of discussion of cyclothymic disorder. And these patients are always going to be a little bit up or a little bit down. So their energy curves are going to probably look like this: up and down, up and down, up and down for upwards of 2 years. And they're never going to have a period of greater than 2 months where they're perfectly normal. And just to give you guys an idea of where a normal person would kind of lie on this graph, it would be right here along this orange line here. And you can see that these people with cyclothymic disorder are going to be dipping up above and down below and up above and down below this orange highlighted region, which we would consider like a normal mood range. So I hope this discussion here clarifies the differentiation between bipolar 1, bipolar 2, and cyclothymic disorder. And I really want you guys to pay attention to the medications we use and their side effect profiles for both bipolar 1 and bipolar 2 disorder management.